To start the webinar in few seconds. Ladies and gentlemen, good evening, everybody around the world. We are here, the Mega Learning. Our slogan is Learn, Engage, and Connect. We are overwhelmed today for this elite group of professors from all over the world, and we are so proud of inviting our dear professor. We are tonight, we have four professors, Professor John Doyle, Professor Hidalgo, and Professor Nisreen Rifai. And we are so delighted and so proud for this exclusive session to be chaired by our dear Professor Jihan Al-Kholi. She's a professor of anesthesiology and intensive care medicine in Cairo University. Professor Jihan Al-Kholi is an eminent professor, and she is a member of many educational and quality control in the university. She is very well known as national and international speaker, and all floors for you, Professor Jihan Al-Kholi. Thank you very much for being here.
Thank you very much, Professor Saad, for the wonderful introduction for tonight's session. Good evening, everybody. By way of introduction, I'm Dr. Jihan Al-Kholi, Professor of Anesthesia, Surgical ICU and Pain Management, Cairo University. I welcome you all in our scientific session tonight. First, I want to thank all my eminent professors sharing and participating in this session. I want to thank all our dear guests, dear attendees and participants. They are actually very dear, and some of them are my seniors. So it's my pleasure actually to be with them. Furthermore, I want to thank Professor Dr. Saad Mahdi, Mega Anesthesia. Without your help and the continuous support, as you say, it's our anniversary. It has been a year working with you, Professor Saad, and with your wonderful team processing these sessions. Now, it's my pleasure and my honor to introduce Professor Dr. Doyle. I have the honor that I met him previously in anesthesia conferences here in Cairo with our late professor, Dr. Abdallah Fikri. Dr. Doyle is with the Department of General Anesthesia, Cleveland Clinic, as well as Professor of Anesthesia at Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. Professor Doyle received his MD in 1982, Ph.D. in Biomedical Engineering in 1986, both from University of Toronto. He received his Canadian board certification and his American certification back in 1989. Dr. Doyle has a long-standing interest in ENT anesthesia and difficult airway, which I really share with you, and very glad that we share same specialty, as well as an interest in the use of technology in medicine. Actually, the resume of Professor Doyle extends and extends. It's all wow. So we are all ears to listen from you about airway challenges. Please, Professor John, go ahead.
Thank you so much for the kind introduction. And let me share the screen here. It's entitled Airway Challenges, Lessons from the Morgue, because a lot of the initial things I learned about clinical airway management began with unfortunate deaths and coroner's reports. So we're going to begin by taking a look at some of the objectives. The first objective is to understand the special problems that may occur in some difficult airway patients. The second is to understand how difficult airway algorithms, such as the ASA, American Society of Anesthesiologists difficult airway algorithms, may help with these patients. And although I'm not going to go into algorithms in a lot of detail, you'll understand that there are algorithms published from around the world, including from the UK, as well as from countries as diverse as Italy and China and India. So depending on what resources you have, there is an airway algorithm to match. Finally, I want to talk and put special emphasis on the issues with the difficult extubation patient and take a look at some of the techniques that are available. And a way to start all of this is with some airway horror stories, because the horror stories of things that went wrong can tell you about how we can prevent such problems in the future. The first airway story is a patient whose jaw was wired shut after maxillofacial surgery, and then the patient had an epileptic seizure and vomited, and they were unable to open up the airway in time because someone had forgotten to have a set of surgical pliers so that they could rapidly open up the mouth to secure the airway. And this patient aspirated and died. One case that we experienced was that the endotracheal tube cuff wouldn't deflate because the pilot line was sealed shut and the patient biting on the tube. Even when the patient's mouth opened up again, the pilot line was sealed shut. And this was difficult extubation indeed. In another case, the endotracheal tube was sutured into the soft palate by the oral surgeon, and the patient was ventilated overnight. And when it came time to extubate, they hadn't communicated to the new team that the tube had been sutured in place. And when they were unable to remove the endotracheal tube and the patient cried out in pain as best they could with the tube in place, when they pulled on the tube, they figured out something was wrong, brought them back to the OR, had the anesthesia people take a look, and what did they find? The tube was sutured in place. Here's a case that can be very difficult, parturient with a known difficult airway who now has fetal distress. You have fetal bradycardia, you want to do a stat section, but the patient has a known difficult airway. There's many different options for management of this, all of which entail some very difficult circumstances. Here's a case of epiglottitis in a child where a parent is suspected to have malignant hyperthermia or malignant hyperpyrexia susceptibility. And while ordinarily you would have a child with epiglottitis getting inhalation induction with sevoflurane, the problem is that this child is suspected to have malignant hyperthermia by virtue of their parents having proven malignant hyperthermia. And here's another case, severe epistaxis following extubation after maxillofacial surgery with the jaw wired shut again. These are all horror stories. And in each of these cases, it's not a bad idea to have some sort of plan in place. In the case of the jaw wired shut, it's commonplace to keep the appliance to unwire the jaw immediately available beside the patient. Here's ankylosing spondylitis so severe that the patient's nose is in contact with her chest. And here is a picture of her. This is a case of the late Dr. Andy Ovasapian, the father of fiber optic airway management in the United States, who started the Society for Airway Management in 1995 in the United States. And as you can see, she would be difficult to intubate. She was intubated nasally fiber optically, and that procedure went well. So why do airway disasters occur? Now that I've had the chance to look at airway disasters over a period of some 30 years, here are some of the issues that come up. The patient may be incompletely assessed. For example, they don't see how well the patient can open their mouth. There may be no plan or no preparation should they recognize that there's a potential problem, or no assistant who can help you. You may be overconfident, your ego may get in the way, or you may feel that it's wrong to call for help because of your ego. Or if you get help, you get the wrong help who lacks the experience and judgment that you need. Or you may not have experience using fiber optic intubation, FOBI, or the fear of trying a surgical airway when one is clearly necessary. So this is just a list of some of the airway disaster that have occurred and what the basis for them is. Let me give you some stories that will emphasize this. This is the first coroner's report I got, and this was one of the first cases from about 35 years ago. A morbidly obese man scheduled for a gastroplasty. He was morbidly obese, and his first anesthetic was thiopental and succinylcholine, but they couldn't intubate, they couldn't ventilate well. The succinylcholine wore off, and the patient woke up. And they decided to cancel case and figure out what to do. Remember, this is the days before video laryngoscopy. In fact, even the days before capnography, and certainly the days before the use of supraglottic airways like the laryngeal mask. But it came time to reschedule him, and they decided the problem was that he wasn't sufficiently relaxed. So what they did is they used pancuronium instead of succinylcholine for improved relaxation, arguing that at least pancuronium can be reversed, failing to account the fact that it can't be reversed readily until a lot of it has worn off. They couldn't intubate, they couldn't ventilate, bradycardia set in, cardiac arrest ensued, and there was a coroner's inquest. And this is one of the first cases that came to my attention that may be interested in the problem of clinical airway management. This patient should have had awake fiber optic intubation or awake intubation by some means in any event. A more recent case in my experience was a post-gastroplasty patient. She was morbidly obese as well. She got fentanyl, thiopental, succinylcholine. They couldn't intubate, they couldn't ventilate, but fortunately there was an experienced head and neck surgeon in the room. And there was a decision to have the surgeon do a surgical airway. And the surgeon decided to attempt a formal tracheostomy rather than a quick crike through the cricothyroid membrane. He had difficulty finding the trachea in layer after layer of fat. And although they did get the airway after a period of severe hypoxemia, the patient died eventually. And the lesson there is that when you can't intubate, can't ventilate, and the saturation is going down and bradycardia is setting in, a formal tracheostomy is not the right thing to do. Instead of going through the second and third tracheal rings, you'll want to do a slash with a vertical incision through the cricothyroid membrane and either do transtracheal jet ventilation or more commonly, the scalpel Bushi technique now recommended by the Difficult Airway Society. So with that experience, the American Society of Anesthesiologists and the Difficult Airway Society and others have some recommendations for the known or suspected airway. First, inform the patient about the special risks. Make sure another individual is available to assist, and preferably someone who's quite experienced in airways, and give supplemental oxygen while managing the airway. And typically this would be nasal prongs during fiber optic intubation. You also should remember there's three basic management choices to be made in each airway situation. First, surgical or non-surgical approach, and almost always it's going to be non-surgical with a breathing tube such as a supraglottic airway or an endotracheal tube. Secondly, do you want to maintain spontaneous breathing, or do you want to breathe for the patient following neuromuscular blockade? And typically you breathe for the patient with a ventilator, but sometimes you want to maintain spontaneous breathing. An example of this that's sometimes cited is the patient with an anterior mediastinal mass, or the patient with epiglottitis. You may want them to be breathing spontaneously if fiber optic awake intubation is not straightforward. And finally, awake intubation versus intubation after induction of general anesthesia. And almost all of the time in routine clinical practice, intubation after the induction of general anesthesia is what's done, but awake intubation commonly required in ENT cases where there's tumors or radiation that can make all the structures difficult to manage. There are three situations you must always have a plan for. Awake intubation, and typically this would be fiber optic, but not always. The patient is difficult to intubate, but easy to ventilate, and the role of the supraglottic airway there is very important. And the patient who can't be intubated and can't be ventilated, and that patient will often require a surgical airway if the patient does not wake up and breathe on their own in a timely manner. So here is the American Society of Anesthesiologists difficult airway algorithm in sketch form. I'm not going to go through this in detail. Just to let you know that there's just two approaches, that where you decide for awake intubation and that where you attempt to intubate after the induction of general anesthesia. I would point out though that the ASA difficult airway algorithm is now in its fourth generation, and we expect next year, perhaps even earlier, the American Society of Anesthesiologists will be releasing the fourth edition of the difficult airway algorithm, which will reflect a number of changes in technology, such as advances in video laryngoscopy and advances in jet ventilation, as well as advances in high flow nasal oxygenation that will be taken into account in the next generation of the algorithms. And it's worth emphasizing that the ASA algorithm is not the only one that's out there. The British, the French, the Italians, the Chinese, and the Indians, just to cite some examples, have their own difficult airway algorithms reflecting national preferences and the availability of certain kinds of equipment. This again is just the ASA difficult airway algorithm, emphasizing on the left an approach using awake intubation, and on the right an approach after induction of general anesthesia. And if you have difficulty with intubation, the next decision is, can you ventilate by face mask. And if you can, that's great. If you can't, you want to put in, for example, a supraglottic airway, and then you follow through here. And again, I'd emphasize this will be updated, we expect, in the next 12 months. One question that comes up is, how many attempts should you make at elective intubation? After the first attempt, you may identify that there is a problem you've seen, and it may be remedied by repositioning the head by external laryngeal manipulation to put the glottic aperture into better view, or you may use a stylet or airway introducer, which I commonly recommend. And you may have a third attempt when someone comes by who's far more experienced. But if no success after 3 attempts, I recommend that you wake up the patient to try awake intubation or an alternate plan. That alternate plan may be a supraglottic airway. It may be regional anesthesia, depending on the circumstances. But as a rule, no more than 3 attempts at elective intubation. There are many techniques for difficult intubation. You can use alternative laryngoscope blades. For example, a big floppy epiglottis is often managed using a Miller blade, but more commonly, we go to video laryngoscopy, and a lot of people go directly to video laryngoscopy, such as the glide scope or the McGrath, right off the bat, and don't even bother with classical laryngoscopes. Awake intubation, commonly in some centers, especially for ENT cases, and fiber optic intubation can be done awake or asleep. It's often recommended that you do elective asleep fiber optic intubation just to keep your skills up. Retrograde intubation is practiced in some places where you go through the cricothyroid membrane and have a wire go through the mouth and then intubate over that, but it's not commonly done in the West. And a surgical airway, for example, an emergency surgical airway through the cricothyroid membrane, or a surgical airway done awake with minimal sedation through the second and third tracheal ring, and a surgical tracheostomy done awake is another thing that is often done in ENT cases where the airway is clearly quite difficult. We recommend that you have a difficult airway box or a difficult airway cart that has a variety of things: nasopharyngeal airways, oropharyngeal airways, endotracheal tubes of various sizes, supraglottic airways, such as the laryngeal mask and the iGel. I particularly like the video laryngoscope called the glide scope, but there's others as well. And you'll need sprays and drugs for awake intubation and for fiber optic intubation. Equipment for a cric should you have to go through the cricothyroid membrane, an exhaled CO2 detector, and that's the one that goes from purple to yellow, purple to yellow, purple to yellow, or you can get the fancy one with a waveform, capnogram, and an airway introducer, sometimes called a gum elastic bougie, that you can introduce into the glottic aperture and pass a tube through it. So many different things that you want to have available on a difficult airway cart. Now, mask ventilation is something that is potentially a problem after the induction of general anesthesia. And Langeron, some 20 years ago now, identified some of the factors associated with difficult mask ventilation. Presence of a beard, common in males. Body mass index over 26, very common throughout the world and especially in America. Lack of teeth makes ventilation more difficult. Age over 55 and history of snoring. So multivariate analysis here can predict what situations might make it more likely that mask ventilation be difficult. One of the techniques for difficult ventilation, a 2-person mask ventilation technique. 1 person secures the mask and the other person ventilates by hand. You can use a supraglottic airway like the iGel or a laryngeal mask airway. The use of a nasopharyngeal airway or an oropharyngeal airway can be useful. And then exotic things like rigid ventilating bronchoscopes, that's occasionally used. Surgical airways, transtracheal jet ventilation occasionally used. Typically, if you're able to put in a supraglottic airway, your life is going to be more straightforward, and then you can proceed to intubation. Now, one challenging thing is safe tracheal extubation. What do you do after you've had a hard time intubating and you want to extubate this patient? So extubation is the process of removing a tube from the patient's trachea. Ordinarily should only be done with patient awake and obeying commands, but even so, catastrophes in extubation can occur, such as collapse of the airway when the patient with tracheomalacia. And sometimes it's wise to extubate over tube exchanger, as in any patient who'd be difficult to reintubate. So here's some extubation wisdom over the years. Don't take out anything out of the patient you can't put back in. If in doubt, extubate wide awake. Person who's bucking on the tube may not necessarily be safe to extubate. They may be bucking on the tube, coughing on the tube, but still not opening their eyes to command or squeezing your hand to command. So you can get into trouble even when extubating an awake patient. And sometimes they're awake, but not really awake enough. And I find that this is occasionally the case when we use fentanyl, but you always have a backup plan or a rescue plan. And perhaps the most important thing there is to have extra people around to help. One technique is to use a supraglottic airway as a bridge to full extubation. And the general idea here is that you extubate the endotracheal tube while the patient is reasonably deep, and then replace it with a supraglottic airway, and then remove the supraglottic airway sometime later when the patient's more awake. And then you can reintubate via a supraglottic airway if needed. Now, not all supraglottic airways are the same when it comes to intubating. If you have an iGel, you can intubate a size 7 endotracheal tube through it without too much difficulty. But if you have an LMA Classic, you're not going to be able to fit a very large tube through. And this is worthwhile remembering. So if you're going to try a trick like this, do a test first to see which size endotracheal tube will go through your supraglottic airway. And that's why I prefer the iGel, but there's others as well. Now, a tube exchange catheter can be very useful. And here you can see a tube exchange catheter. This is made by Cook. And here you have a patient on the left who had a lot of surgical reconstruction. Is clearly a difficult airway. And what happens is that you advance your tube exchanger into the airway, sighting it a little bit above the carina, and then you extubate over that, keeping that tube in place. So here's the exchange catheter, and you can see the distal end allows for oxygen insufflation if you wish, or for capnography for that matter. So how would that work? Well, you ensure that there's a leak around the endotracheal tube. Ideally, there should be one. Place in your tube exchanger, ensure oxygenation and ventilation is adequate and the patient is fully awake and reversed, then pull the endotracheal tube over the tube exchanger. And the markings on the tube exchanger will allow you to determine where you are relative to the carina, because you don't want it tickling the carina. That'll just make the patient cough. And then you pull the endotracheal tube away. And if the airway is unstable or lost after pulling it, then you can employ a rescue strategy. And typically that will be to insert a narrow bore endotracheal tube into the airway using the tube exchanger as a guide. One question that comes up is, well, how long should you wait before you can pull the tube exchanger out? And that answers to that with experts vary from 1 hour to overnight. So there's no consensus on that. A lot of people will keep it in overnight. So here is a case report from the Journal of Critical Care, routine use of a pediatric airway exchange catheter after extubation of adult patients who've undergone maxillofacial or major neck surgery. And you can see that patient has that tube in place, that catheter in place that you can use to railroad a narrow bore tube into the airway should ventilation become a problem. In this case, they left it for 6 hours and the patient did not require reintubation after it was removed. Here is another case, and this patient underwent maxillofacial surgery from trauma and required reintubation after 6 hours of extubation. So it shows you there can be a lot of variation in the time for reintubation, should reintubation be required. One warning, this is from 25 years ago, but still applies. Reintubation over tube exchanger is not uniformly successful. Success rate can be enhanced by rotation of the endotracheal tube and simultaneous bronchoscopy. Now, I want to talk about some tricks of the trade that have been circulating around, and these come from one of the internet discussion groups. There's many of these discussion groups and they come and go over time. This is from Yahoo, it's an older one, the Anesthesia Ideas discussion group, where this guy wrote, and that's now 12 years ago, what is the best method for deep extubation? And he writes, can anyone provide a method they prefer most for deep extubation? Being a resident, I have some days go much faster than others when trying different methods, just wondering what others in the real world do. First reply I got was from James Ducato, who is very famous in the airway field. He wrote, intubate through an air cue supraglottic airway, leave it in place, and then extubate the trachea when spontaneous ventilation occurs at the end of the case and allow emergence. And that's akin to the technique I mentioned earlier. He prefers the air cue because you can intubate it through it. Other people prefer the iGel, lots of choices. But he recommends leaving a supraglottic airway in place. Now, another guy wrote from guys in St. Thomas Hospital, I keep my patients on a low dose remifentanil infusion, about 0.1 microgram per kilogram per minute, and wait for them to begin breathing spontaneously, then gently extubate. They hardly ever cough and continue to breathe. And it's well known among the ENT anesthesia community people that a low dose remifentanil can provide for a kind and gentle wake up, not ordinarily achievable by other techniques. And so that's a second method for deep extubation. But what he's talking about here is not really deep extubation so much as extubating in a kind of gentle manner, gently on low dose remifentanil when they wake up. Then a technique that was from one of my colleagues, Dr. Kempen. Here's the Kempen method for deep extubation. And I have his picture here because I really want to give him credit for this. He says, I've been doing this for years while supervising residents. And no waiting means happy surgeons, no coughing, bucking, desaturation, hemodynamic responses makes for safe practice. And so what he says is deflate the endotracheal tube cuff while they're asleep. Lidocaine is instilled into the endotracheal tube. Then you reinflate the endotracheal tube cuff. And the idea here is that when you reinflate the endotracheal tube cuff, there is lidocaine on the cuff that will make it less likely that it will irritate the airway. The patient can then be emerged in your usual manner and extubated without knowing the endotracheal tube is in place, much like after LTA use, LTA being the laryngotracheal atomizer. Allow the patient to undergo relaxant reversal and resume adequate spontaneous ventilation. Test for tracheal anesthesia by rapidly deflating and reinflating the cuff and look for any change in respiration. If the patient coughs on cuff deflation testing, you can repeat the dose and repeat it as well. If no reaction, remove the tube between 0.0 and 2 MAC. There's typically no change in respiration, and now you have extubated irrespective of depth of anesthesia. Now, he mentioned some caveats: aspiration risk, full stomach risk. Those are clinical contraindications. You don't want to risk aspiration. The less the endotracheal tube is inserted beyond the cords, the less amount of trachea needs to be topicalized. 1% solutions are typically effective, but he recommends stronger solutions in smokers or individuals with thick secretions, and 2% lidocaine and 4% lidocaine are available. Be sure to inject the lidocaine down the endotracheal tube and not into the circle system. And he recommends slow installation of 5 cc's of 1, 2, or 4% lidocaine before reversal or before lightening the anesthesia depth. So this is his technique. The lidocaine lasts about 20 to 30 minutes, so don't instill the lidocaine too early or it'll wear off. As extubation is performed too soon before the end of surgery, you may need to provide mask anesthesia for some time. Smokers may require 4% lidocaine because of the thick tracheal secretions and require 1 to 2 minutes before, to facilitate penetration. And then he goes on, start with patients with good airways and good health until you gain confidence, so you get experience with this, or just see how it will aid improve your deep extubation routine. Patients will tolerate the endotracheal tube to much lighter planes of anesthesia with the lidocaine anesthesia, often opening their eyes in response to their name, will stick out the tongue on command, and then the tube is removed, awake without coughing, and they emerge as might with a supraglottic airway or a laryngeal mask airway. Remember that laryngospasm is abnormal reflex to airway stimulation in the second stage of light anesthesia. However, if you remove the stimulus, you'll find no reflex. Now, what's interesting at this juncture is that there is still a number of people who are not a fan of deep extubation, and I more or less find myself in that category. This guy writes, his name is Terry Weber. I appreciate all the hints for the best technique, but I must confess I've never been a big fan of deep extubation. Over the years, I've had several partners who are fans, and it always seemed that they were presenting their latest case of laryngospasm or airway disaster in the ICU or PACU. Deep extubation should really not be required to wake a patient up without an inordinate amount of coughing or bucking. And the tales of patients coughing or bucking or bleeding to death or exploding vessels in their head, for the most part, the stuff of lore and the bullshit of surgery. Now, that being said, I myself remember very much a case where the patient was coughing on the tube after a thyroidectomy, and I saw the hematoma forming at the surgical site before my eyes before extubation because of the cough. We immediately put this patient back to sleep instead of extubating. And we spent another 90 minutes, an hour to 90 minutes or so, finding the bleeder and taking care of everything. So you can get bleeding as a consequence of coughing in some airway situations, and particularly with thyroid and parathyroid surgery. So this guy writes, for what it's worth, I almost always extubate awake with a decent slug of opioid on board. Most patients usually open their eyes when you call their name and open their mouth when you ask. There's nothing more elegant than that. And that's where we get into the value of remifentanil as a drug that can make extubation a little bit more straightforward. And this is what from Sandy Hancock from Adelaide, Australia. Now, I want to close with taking a look at a very important study. This is the 4th National Audit Project of the Royal College of Anaesthetists, the NAP4 study. It's now 10 years old, and it was entitled Major Complications of Airway Management in the United Kingdom. It's very valuable. You can download it here. And here are some of the key points. About 42% of anesthesia events reported had a primary airway event indicating intubation difficulty, responsible for 13% of airway-related mortality. And these were ASA1 patients, typically male, typically aged less than 60. And a potential practice inadequacy identified that a formal airway assessment was recorded in only 35 of 133 cases. So remember, lack of assessment can be a problem. Aspiration was the single most important primary cause of mortality rather than cerebral hypoxia. And that's an interesting finding. Nearly 50% of the events followed head and neck surgery, and approximately 70% of these reports were associated with obstructive lesions within the airway and reports indicating evidence of poor anticipation and planning. Many of these patients were obese, representing twice as frequently in the population that suffered incidents than those that did not. Now, here's something interesting. Use of a needle cricothyroidotomy as a rescue technique, the transtracheal jet ventilation technique, suffered a 65% failure rate with numerous mechanisms of failure: equipment, training, insertion technique. And this is why a number of people recommend avoiding transtracheal jet ventilation as a rescue technique and going with the surgical airway through the cricothyroid membrane with a needle, with a scalpel, bougie, tube technique, typically a size 6 tube. A quarter of events involved emergence, usually resulting in airway obstruction from laryngospasm, biting on the airway device, or airway swelling. Biting on the airway device is something that can be prevented, of course, by using a bite block, and that can be easily made out of some of the gauze immediately found. At least 1 in 4 major airway events were in the ICU or the emergency department. In the case of the ICU, it was often related to a tracheostomy problem. Displacement of tracheostomies caused 50% of ICU events. And a majority of events in the emergency department concerned difficult or failed tracheal intubation during a rapid sequence induction. Surprisingly, capnography was often not used or was misinterpreted, especially during cardiac arrest. So the executive summary suggests that when a potential difficulty with the airway is identified, rather than an airway plan, a strategy is required. An airway plan suggests a single approach, whereas a strategy is a coordinated logical sequence, which basically means you need a plan A, and then a plan B if you run into trouble, and a plan C if plan B fails. And among these things, among the most important thing is to have extra help at hand when you get into trouble, to call for help. Of note, events were reported when supraglottic airway devices were used inappropriately, such as aspiration. And sometimes supraglottic airway devices were used to avoid tracheal intubation when really they should have been intubated and really should have been intubated awake. The author suggests that choosing the safest technique for airway management may not necessarily be the anesthetist's most familiar. And so sometimes people would use a supraglottic airway instead of, for example, an advanced technique such as this shown here. This is a retrograde technique where the wire goes in through the cricothyroid membrane, out through the nose, and they're doing a nasal intubation in this manner. The author also suggests that obesity is to be recognized as a risk factor for airway difficulties and strategies and modified accordingly. This patient, who is one of my patients, he had a BMI of 163 and he was 980 pounds, which is 450 some kilograms in weight. So just to close, what will we learn about the about the NAP4 study? More than half the patients were male, ASA 1 to 2. under 60. These are not the people you would expect to get into trouble. Aspiration was the most frequent cause of anesthesia-related airway mortality. Obese patients disproportionately represented. Obstructing airway lesions generated a number of complications. Many reports show poor technique in planning, and that may require awake intubation that some people were uncomfortable with. Cricothyroidotomy by anesthetists was associated with a high rate of failure because they used the needle technique, transtracheal jet ventilation, instead of the scalpel bougie tube technique that is recommended by the Difficult Airway Society. And omission or incorrect interpretation of capnography led to undiagnosed esophageal intubation. And elements of poor management were reserved in the majority of airway complications and in most deaths. I want to close with this quotation. This is an excerpt from a fatal incident in 2010. The cause of death was barotrauma as a result of perforation of the right lung as a complication of anesthetic administration. The relevant underlying condition was a fracture of the distal phalanx of the right little finger. He broke his right little finger. The termination of the anesthetic procedure, allowing the patient to wake up, was a reasonable precaution which might have prevented his death. There were several opportunities when a decision could have been taken. There was a failure to observe and follow clear operating instructions for the safe use of an airway exchange catheter, which I introduced you to earlier. There was a breakdown in communication among the anesthesia team as to the experience of those present in the use of an airway exchange device. The most striking feature of this inquiry was that none of the three experienced anesthetists intended given any consideration of the fundamental option of waking up the patient, particularly to having regard to the minor surgery involved. Anesthetists need to be actively aware of that option, particularly for anesthesia for elective procedures for minor or non-essential surgery. As many people would say, this could clearly have been done under regional anesthesia, a beer block, or even local infiltration. But instead, they attempted general anesthesia and then proceeded, instead of waking up the patient when the airway was not managed, they ended up, unfortunately, killing him. The lesson is it's okay to wake up a patient and abort the anesthetic if airway problems are encountered. So I would like to bring my discussion to an end. Those people who want a copy of the slide set, I'm pleased to provide them to you. And in addition to the material I presented here, there are some additional cases in the slide set from the NAP4 study that you would find useful. But even better, if you go to the website I mentioned, you can download the complete report as a free PDF. So there you go. Thank you very much. And I look forward to participating in any questions as they arise. Thank you very much.
Thank you very much, Professor Doyle, for this comprehensive and interesting presentation. Actually, you started with the horror stories that makes brainstorming for everybody in the anesthesia field, that some of us have faced these horror stories with a pregnant female and fetal distress with a difficult airway, with epistaxis after wiring of the maxillofacial injury. Then you took us through maybe a roadmap, tips and tricks, why airway disasters do occur, for incomplete assessment, having no plan or having one plan. And you mentioned that we should have alternative plans, plan A, B, C, maybe up to plan Z, no preparation, no trained assistant, overconfidence, and maybe fear of calling for help, which should be quite early, actually, lack of fiber optic experience. Then you took us through standard plans. It is either surgical or non-surgical airway, spontaneous versus muscle relaxant and having the patient ventilated, awake versus induction of GA. How many attempts? That's a wonderful question that we got the answer from Professor John Doyle tonight. It is never more than 3 attempts. After the first failed attempt, reposition your patient, external laryngeal manipulation, use whatever help you have, stylet, bougie, and try to intubate. After the third, you should stop maybe earlier to prevent complications, bleeding, edema, etc. Extubation is a decision that should be done with wisdomly, as you mentioned, sir. Safe tracheal extubation, maybe we can do it while keeping the patient oxygenated, fully awake and reverse it. Interface with supraglottic apparatus to bridge it to full extubation, iGel, AirQ, etc. Tube exchanger, cook tube exchanger, or any other exchangers. I thank you very much for these tips and tricks, which I really get benefit myself. And now we have one question up till now, Professor Doyle. It is from Dr. Sharif Abdulatif. He's asking about submental intubation as an alternative to surgical airway in cannot ventilate, cannot intubate situations, sir.
So a very interesting question. Submental intubation is occasionally done under controlled circumstances, but very few people are skilled in it. I'm almost certain that this technique would be too slow even for the skilled practitioner compared to the quick vertical incision, identifying the cricothyroid membrane, putting in your scalpel, rotating it, putting in your airway introducer, and then passing a size 6 tube over it. That is the technique that can be done in under 30 seconds. And there's even videos on the internet showing how it can be done under 30 seconds. Whereas it's unlikely that submental intubation could be carried out as an alternative for the can't intubate, can't ventilate scenario. However, it could be an alternative to tracheostomy in a number of cases. And there is some interesting literature on that. And in some parts of the world, submental intubation is carried out with relative frequency, but not that much in America.
Thank you very much, Professor Doyle. I guess we'll get more questions after a while, so keeping you with us would be our pleasure to answer the coming.